abdominal swelling, abdominal lump, abdominal mass. So we'll start with the clinical approach to the patient. We'll start with the history taking in the ordinary way, whether you have a male or a female patient, how many years old, married or not married, his residence in a village, in a rural or urban space, and if he is having special habits. So the special habits will be of interest in cases of some abdominal tumors, especially carcinoma of the pancreas. Alcoholism may be related to a liver cirrhosis, regenerative nodule, or hepatocellular carcinoma resulting from cirrhosis or arising on top of cirrhosis. I see something trying to open. I hope يوسف yeah. في حد جنبكم يعني. Okay, so the patient is coming complaining of, as we have said, one of two is either pain or an abdominal mass. In the present history, we have to revise number one analysis of the patient complaint, where the condition started since by the appearance of either pain or a swelling. It's having a progressive course, regressive course, or an stationary course. Now the abdominal case really represents a general revision of all the body systems. So we have to revise all the body systems. Uh, Here we start with the upper gastrointestinal symptoms. Ask your patient about pain, heartburn, nausea, vomiting, eructation, hematemesis, change in the color of sclera, urine, and stool color. Urine and stool color. Number two, interrogate about the lower gastrointestinal symptoms that are mainly change in the bowel habits. Is there any progressive constipation, diarrhea, tenesmus, bleeding per rectum, melena, intestinal colic, and so on? Interrogation about the urinary system, as pain may arise from the urinary system, as well as the colic, like ureteric or renal pain, may arise from this system. So you should ask about dysuria, frequency of micturition, passage of urinary stone, hematuria, necroturia, retention of urine, and evidence of renal failure. By necroturia, we mean epithelial cells and tissue debris descending down with the urine. As we have said in the previous history of head and neck mass, it may be etiologically related to trauma, so we should ask about previous history of tumor. Then it may be an inflammatory, so we should ask about the general evidence of inflammation. Is there a history of fever, headache, sweating, malaise, and local evidence of inflammation that are hotness, redness, tenderness, swelling of the skin overlying the abdominal state. I hope you are following. It's okay. I'm waiting your answer. Are you following me?
Yes, okay.
Okay, and you are following the photos on the WhatsApp, so no problem. Um, Etiologically also, if the condition is a neoplasm, it's a tumor. This tumor may be either a benign tumor or a malignant tumor. So if the possibility of malignancy in the abdomen is suspected, you have to ask about liver metastasis, lung metastasis, brain metastasis, and as well bone metastasis. Lastly, we shift to the past history. Ask about past history of bilharziosis, traveling abroad, because this may be related to the development of a famous abdominal mass, which is a hydatid cyst. History of treatment of tuberculosis, previous surgical operations, liver disease, diabetes, hypertension, typhoid. Okay, repeat again. The items in your past history is bilharziosis, traveling abroad, tuberculosis, surgical operation, chronic liver disease, especially cirrhosis, diabetes, hypertension, and typhoid. Then we shift to the family history. We say there is or there is no family history of similar conditions. This may be of interest. In one case is the hemolytic anemia, because hemolytic anemia may be associated with congested spleen. So the abdominal mass and the left hypochondrial pain may be of splenic origin. In the presence of a similar history in the family, you can suspect the different types of hemolytic anemia. Another example of the family history is a cystic disease, because it's a congenital condition. It may affect the liver, affect the pancreas, and other abdominal organs. Polycystic disease of the kidney. So the presence of a family history of cystic disease anywhere in the body organs may be of interest. Another very important point is the family history of cancer in general. You know, there is what's called the family history syndrome, the family cancer syndrome. So if there is cancers in the family, you can suspect that your patient complaint is caused by a, a familial condition, which is the family cancer syndrome. Most or a good percentage of cases of abdominal pain and abdominal mass may be related to gynecological troubles. So more than half of your patients will be females in their fertile period. So you should gain, especially in the abdominal case, a full gynecological and menstrual history. To revise this gynecological history you ask about, I see something is trying to open. Okay, but nothing is appearing. Let's continue as we are. You ask about the age of menarche. That's the beginning of menstruation. Uh, any abnormalities in the menstrual cycle, menorrhagia, increase the amount, and increase in the time of the menstrual cycle, more than 3 to 5 days, presence of any vaginal discharge, and then you ask about her gravity and parity, that are the number of pregnancies and the number of labors. Before going into the general examination, I'd like you to understand what are the types of pain the patient with an abdominal complaint may come complaining of. He may come saying, I'm having a dragging pain, a heaviness like pain. Another one says that I have burning pain. But if I ask you what's the most common type of pain resulting from an abdominal disease, any one of you can answer which is the commonest type of pain of abdominal problems. Yes, uh, I don't ask about the site, but the character, the type of pain. We can say it's the quality pain. Quality pain. Anybody of us has at a time, sure, he has experienced a quality pain. Okay. So again, if I ask, how can you define colic? What's colic? Colic is a griping type of pain. I'm sorry, in Arabic it means يعصر العيان. It's a griping type of pain. This griping type of pain is coming into ascendo, that is raising in the amplitude, then it descendo, it decreases down so that the patient can get periods of rest. He is free of pain. So it rises, it decreases, and it comes into the baseline where the patient is having no pain. So this is the cause of what we call griping type of pain. Abdominal colic, again, is the most type of abdominal pain. Um, so the second question in this common type of abdominal complaint, what are the types of colicky pain you can tell us? These types include number one, intestinal colic. It's the most common type. Even a patient is having a food intoxication will have intestinal colic. The presence of obstructing thing, the part proximal to the obstruction will try to push the obstruction so that a colicky pain will result. Yes, okay, you understand? So intestinal colic is a common type of abdominal colic. The second is the ureteric colic. Suppose there is a stone in the ureter, so that the smooth muscles in the ureter will try to compress, uh, trying to push this type of obstruction. So the second type is ureteric colic. We come to the third type, it's controversial whether it is colic or pain. That's the biliary colic. Most of the surgeons prefer to call it biliary pain rather than biliary colic. Why? Colic to occur, there must be a hollow organ with a layer of smooth muscle fibers, outer longitudinal and inner circular layer. Second, there should be an obstruction. Third, the organ will try to push this type of obstruction. And it's a fulfilling the criteria of colicky pain that's going into ascendo, decreases down into descendo, and having free intervals in between. If we look to the biliary pain, we find that pain remains in the patient for 1 day or 2 days. So it's preferred to call biliary pain. The second cause, histologically speaking, if you examine the wall of the gallbladder and the wall of the common bile duct, you will find that muscles are scattered patches of muscle. They don't form a definite layer. There is no circular inner layer and longitudinal outer layer. A fourth type of abdominal pain is spasmodic dysmenorrhea, and this is a functional obstruction. It occurs in young girls due to functional obstruction, spasm of the cervix uteri, so that there is a very severe colicky pain that occurs during menstruation. So we have four types of abdominal pain or pain that occurs in abdominal cases that are intestinal colic, ureteric colic, spasmodic dysmenorrhea, biliary, what we have preferred to call the biliary pain rather than to call it as biliary colic. Okay, I hope you are understanding. Yes, sir. Anybody here? Are you all leaving? You can. Um, what are the number of attendants now?
17, doctor.
17. Very good. Okay. Are you following me in the WhatsApp photos?
Yes.
Yes. Okay. Okay. Uh, our clinical follow-up of the case will go into the general examination after ending the history taking. You describe the attitude and the gait of the patient. So I can say the patient is sitting quiet, oriented, cooperation with the examiner, with normal decubitus, that's the sleeping attitude on the examination table, and is having normal gait. Then record the basic parameters, the pulse, temperature, and blood pressure. Search for pallor, cyanosis, and jaundice. By the way, jaundice to be detected clinically, the serum bilirubin level should be more than 2 milligram per 100 milliliter. So you search for pallor, cyanosis, and jaundice. Palpate the neck for neck lymph node enlargement. Palpate for the thyroid. Do a complete chest examination and heart examination. In the upper limb, search for clubbing of fingers. I hope in the surgical tutor about head and neck swelling, we have illustrated what's clubbing of fingers and how to measure it. Search for palmar erythema. That means the presence of cirrhosis. Duodenal contraction, it means also cirrhosis. Uh, but let us ask if we are in the general examination searching for cervical lymphadenopathy, which of the cervical lymph nodes are you looking for? I'm looking for the lower deep cervical lymph node, especially on the left side. This is called Virchow lymph node. And so if there is an abdominal malignancy, this enlargement of the Virchow lymph node or the left supraclav is called Troisier sign. Troisier, Troisier sign. How it comes? Suppose we have an abdominal malignancy like that of the colon, of the pancreas, of the stomach. So the regional lymph node will go lastly to the para-aortic lymph nodes. From the para-aortic lymph nodes, lymphatic emboli are carried along the main lymphatic trunk of the abdominal drainage, which is the cisterna chyli. From the cisterna chyli, it handles lymph into the thoracic duct. This thoracic duct is the major lymphatic vessel that opens into the junction between the left internal jugular and the left subclavian vein. If there is a heavy malignant emboli, so that the thoracic duct will find that the junction is crowded with malignant cell. It undergoes what's called retrograde lymphatic spread. By side branch lymphatics, it goes from that junction into the left supraclavicular lymph node that performs a very interesting clinical sign, which is the presence of enlarged supraclavicular lymph node on the left side, what's called the Virchow's lymph node or Courvoisier sign. Again, the sequence of events for enlargement of the left supraclav is abdominal malignancy, regional lymph nodes, para-aortic lymph nodes, cisterna chyli, thoracic duct on the left side that should drain into the junction between the left internal jugular vein and the left subclavian vein. If there is crowding by malignant emboli, so it will search for another retrograde lymphatic spread via side collaterals of the lymphatics that will go to the left supraclavicular lymph nodes. Are you following me? It's okay. As we have stated in our start of this clinical seminar, we have said that abdominal clinical presentation is either pain, we have discussed this half of the seminar, or maybe an abdominal mass. Okay? If you look in the first drawing on your WhatsApp, you will find a diagram of the surface markings of the anterior abdominal wall, because it makes it easy to describe whether pain or a swelling is lying in which part of the abdomen. This diagram is obtained by two transverse planes and another two vertical planes. The two transverse planes, number one is the transpyloric plane. The above or the upper one, which is horizontal, is the transpyloric plane. The lower one is a line connecting the two highest points of the iliac crest. And then there are two vertical on the right nipple line that's passing into the mid-inguinal point downward, and mid-inguinal point on the left side as well as on the right side. So the abdomen, we can say it's divided clinically into 9 regions. Follow these regions by their numbers, that are the right hypochondrium, number 2, the epigastrium, 3, the left hypochondrium, 4, right lumbar, 5, umbilical, 6, left lumbar, 7, right iliac fossa. The one in the middle, lower down, is the hypogastrium. Simply, they sometimes call it the suprapubic. And then number 9, the left iliac fossa. The left iliac fossa. Again, two transverse planes and two vertical planes. by which the abdomen is divided into 9 regions. You should take them by the numbers that are depicted in your WhatsApp follow-up. We can say them once more. The right hypochondrium, epigastrium, left hypochondrium, right lumbar, umbilical, left lumbar, right iliac fossa, hypogastrium, and left iliac fossa. So if we describe an abdominal mass, we shall say it's lying in the part hypogastrium, right iliac fossa, epigastrium, hypogastrium, right lumbar region, left lumbar region, and so on. The patient is lying now supine. You are standing by the right side of your patient and then start your examination. Steps in examination of an abdominal mass. The inspection, you say the abdomen is distended or it is of a normal contour. Anybody of you can tell me what's the normal contour of the abdomen? Yes? Yes, what is the normal contour? In order to know the abnormal, you should know the normal. Okay? Are you following me?
Please, doctor, repeat the question.
Repeat the question. What is the normal abdominal contour? In order to understand the abnormal contour. Contour, تشكيل, shape. Yes, we can say the normal contour of the abdomen is scaphoid abdomen. Never forget the term scaphoid abdomen. What do you mean by scaphoid abdomen? This means that the abdomen is concave in both the vertical dimension and in the transverse dimension. Sorry enough, in Egyptian patients, we never see the scaphoid shaped abdomen because there is fat, and this fat will lead to a convex appearance rather than a concave appearance of the abdomen. But the normal anatomical contour, if there is no obesity, will be the scaphoid abdomen that's concave from up down and from side to side. Again, it's called the scaphoid contour or scaphoid abdomen. Then ask the patient to respirate, to take breath and inspiration followed by expiration and comment with movement with respiration. Is the abdomen moving freely with respiration or not moving freely with respiration? In addition, you should know that respiration in a female is mainly thoraco-abdominal, while respiration in the male is abdominothoracic. The male uses the abdominal muscles in the respiratory effort more than the thoracic muscles, while female uses the thoracic muscles rather than the abdominal muscle. So if you're having a patient, you say that the abdomen is moving freely with respiration, naturally the movement will be up and down with respiration. Or there is restricted mobility. We say this restricted mobility in the presence of inflammatory lesion, in the presence of peritonitis, perforated appendix, perforated duodenal ulcer, there will be limitation of the abdominal wall movement. The following item, is there scars of previous operations or no scars in previous operations? Because if you interrogate about the scar, what type of operation the patient was having, you can got an idea about the present disease the patient is complaining of. Then examine his umbilicus. This is very important to examine the umbilicus. What is the significance of examining the umbilicus in the presence of an abdominal mass? If you examine the umbilicus, you may find number one, nodule. You know the name of this nodule? It's called Sister
Sister
Joseph.
Mary
Yes,
Mary Joseph.
Mary Joseph. Yes,
Sister Mary Joseph.
Mary was a nurse of Dr. Mayo, and during her nursing care of patients with malignant abdominal tumors, she noticed that the advanced cases are having a nodule in the umbilicus. She informed Dr. Mayo, and they described it by the name of his nurse that discovered the condition, Miss Mary nodule. Okay, or Joseph, Sister Joseph. Sister means the nurse, Joseph, Mary Joseph, but the manuscript is owned to Dr. Mayo, that that's famous for him, the Mayo Clinic in the USA. Okay, another conditions we may find in the umbilicus. So if you find that there is unfolding of the umbilicus that looks like an umbilical hernia, this means that there is either ascites, there is a huge organomegaly, whether it is splenomegaly or hepatomegaly, that leads to unfolding of the umbilicus. The third point in examining the umbilicus, and I hope you follow me, I may find discharge from the umbilicus. Discharge. Look here, sir, this discharge may be feculent, intestinal content. Can you give me the condition that leads to intestinal content discharge from the umbilicus? Yes, it's a patent
Hernia.
vitelo-intestinal duct. That is the embryonic origin of the midgut loop. It's connected to the side of the umbilicus by the vitello-intestinal duct. It should be obliterated, but if it remains patent, intestinal content will come out through the umbilicus. The disease is patent vitello-intestinal duct. The urachus is also connected to the umbilicus, and this connection should be obliterated. If it continues to be patent, it will discharge to the outside, what's called patent urachus. So we may find intestinal content, we may find urine. Now the question to you, if I find blood discharge from the umbilicus, I would prefer clinically to say sanguinous rather than blood discharge. Sanguinous discharge, yes, we find this in ectopic uterine mucosa. Ectopic, what's called endometriosis. So that this sanguinous discharge from the umbilicus naturally, it will occur in female and it characteristically occurs at the time of menstruation. So examining the umbilicus is of a very interesting importance in the clinical diagnosis of abdominal case. You may find Sister Joseph nodule. You may find unfolding of the umbilicus. Number three, you may find discharge, and discharge may come in the form of urine in patent urachus, intestinal content in patent vitello-intestinal duct, and maybe blood or sanguinous discharge in cases of endometriosis. That means presence of ectopic endometrial mucosa. So it occurs at the time of menstruation, and naturally it will occur in females. Okay, are you following me? Then you start your palpation in the form of superficial palpation and then deep palpation. In superficial palpation, you can detect the presence of hotness in inflammatory lesions and rigidity in cases of also peritonitis or inflammatory lesions inside the abdomen. Then do your deep palpation. It's done by your right hand. You can palpate the liver, the spleen, the kidney, and any other additional abdominal mass. Describe what you have palpated. There is a swelling lying in which region, as we have said, the 9 regions of the abdomen, or it may be occupying more than one region or 2 regions if it is a huge swelling in the abdomen. Comment on the edge, is it round or not round, it's sharp or not sharp. Uh, can you get the upper boundary? Can you get the lower boundary? Because in a pelvic abdominal swelling, you cannot get the lower boundary. And in a case arising from a site which is above the ribs, like the enlarged spleen, where it comes from the trops area and then descends down in the abdomen, I cannot get the upper boundary of the swelling. Then comment on putting your hand on the lower pole of the swelling. Ask the patient, take breath and do expiration, and comment whether the swelling is moving up and down with respiration or is not moving up and down with respiration. Look here, we have a general rule that says that any organ which is related to the diaphragm can move up and down with respiration. And this relation to the diaphragm may be either direct relation or indirect relation. Let us revise our anatomy. If there is an enlargement of the spleen, it's related, okay, to the diaphragm, so it moves up and down with respiration. A liver mass moves up and down with respiration. Another example for a mass which is indirectly related. If there is a mucocele, that's an enlarged gallbladder as a result of acute inflammation full of mucus, ask your patient to take inspiration and give expiration. It's also moving because this enlarged gallbladder is related to the liver. Consequently, the liver is related to the undersurface of the diaphragm. So a gallbladder mass, say a mucocele or empyema of the gallbladder, will move up and down with respiration. Suppose we find that the abdomen is diffusely enlarged. Yes, message. What's this message? It doesn't open. Message. Anymore. متابعين سامعين؟ أيها الشباب سامعين؟
سامعين يا دكتور.
Okay, كمل. Suppose in my examination that I find the abdomen as a whole is enlarged. There is diffuse enlargement of the abdomen. Remember the letter F, because this diffuse enlargement of the abdomen may indicate fat, that's obesity, as we have said in the start of the clinical seminar, air or flatus in cases of obstruction, fluid, that's ascites, feces, intestinal obstruction, fetus, that's your patient is a pregnant lady, nothing more. And the sixth cause is a flapping mass or flipping mass. Flipping means a huge mass, say a huge ovarian cyst. So the first item in the interrogation of your abdominal mass, there is a first possibility of diffuse enlargement of the abdomen. I say, remember the letter F, so it may indicate fat, flatus, fluid, feces, fetus, and flipping tumor. That's a very huge tumor. Okay. The last item in our clinical seminar is the interpretation of the different abdominal masses you may be confronted with. We have agreed to describe them by the region. So there may be a mass in the right hypochondrium above. Revise your map again of the abdomen, a mass in the right hypochondrium. It may arise from the liver, maybe a liver mass, and this may include liver abscess, whether it is biogenic or amoebic. It may be hepatocellular carcinoma. It may be metastatic carcinoma of the liver. May not be a tumor whatsoever. We may find a congenital tongue-like swelling in female, which is called Riedel's loop. Riedel's loop. It's an anatomical finding. It's not a tumor. May come from a cirrhotic nodule. Cirrhotic nodule. Hydatid disease or hydatid cyst, or a mass indirectly related to the liver that's arising from the gallbladder, mucocele, emphysema, or even carcinoma. The kidney is a retroperitoneal structure, found inferior to the liver. It may include renal cyst, renal tuberculosis, hydronephrosis, renal abscess, renal tumor, polycystic or multicystic disease of the kidney. The condition may be also due to carcinoma of the hepatic flexure or a mass of intussusception. Mass of intussusception. You know, intussusception means that the ileum will enter into the cecum and the ascending colon. It goes up, so that it may present as a mass in the right hypochondrium. This is common in infants, 3-4 months. But in such a case, it's idiopathic intussusception. Still in the adults, we can have an intussusception if there is an irritating lesion, like a submucous lipoma or a polyp of the intestine. It will initiate the intussusception, or the polyp of Peutz-Jeghers syndrome. We will know later on. Anyhow, the presence of a mucosal lesion will irritate motility of the intestine and can lead to an intussusception in the adult. Even carcinoma of the cecum may present as a mass above early in the disease, because this mass presents an intussusception. So these are the items included in right hypochondrial mass. On the other side, the left hypochondrial mass, it may come from the spleen, and it may come from the left kidney, may come from the stomach, cases of carcinoma of the stomach, pancreas, naturally here arising either from the body or tail, carcinoma of the body or the pancreas, and in the tail there may be a pseudo pancreatic cyst. Same lesions On the right kidney, you repeat them again for a mass in the left kidney. In the left hypochondrium also, you may find carcinoma of the left side of the colon. But I'd like you to understand something here. In front of you, the left colon, the obstructing carcinoma is lower down. What you are feeling is not actually the carcinoma, but it is the impacted feces above the level of the tumor, or what we call dammed stool. Dam. Dam means sad. Dammed stool behind the obstructing carcinoma. So in your diagram, you will find feces and carcinoma. What's felt is actually the feces and not the carcinoma. The carcinoma is usually of the stenotic type. It will not be palpated, but the mass presents the damned stool above the level of obstruction. We come to the third point, which is an epigastric mass. It's very easy to imagine the anatomical structures in your site and then build up the pathological condition. So from the stomach, you may have carcinoma of the stomach, still pseudopancreatic cyst, something arising from the transverse colon, like carcinoma of the transverse colon, mass arising from the omentum, like mesothelioma of the omentum, or erythroperitoneal mass that comes from amalgamated malignant lymph nodes in the epigastric region. More down, we have the umbilical region, still a large mass of carcinoma of the stomach, ileomyoma or ileomyosarcoma. From the transverse colon, we have tumor or impacted feces. These are the most important, never mind about the remaining part. Down to the right iliac fossa, and this is a very rich site of an abdominal mass. This mass includes mainly appendicular mass. Secondly is carcinoma of the cecum. Third is Crohn's disease of the ileocecal region. What's an appendicular mass? If the appendix is inflamed, the omentum, which is the policeman of the abdomen, will come and adhere. Intestinal loops will come and adhere, so that it will form a mass around the appendix to protect against generalized peritonitis. So an appendicular mass is a misnomer. It's not really a mass, but it is an inflammatory process. Second is the carcinoma of the cecum. Third is regional ileitis or ileocecal Crohn's disease. What's more important, on the right iliac fossa to the right and on the left iliac fossa to the left is gynecological causes. Ovarian cyst presents a good percentage of cases or of right or left iliac fossa mass. Ectopic kidney mass developing in an ectopic kidney. As you know, the kidney develops lower down and then goes up in its normal anatomical position. On reverse to the testis. The testis develops up at the level of second lumbar spine and then it descends down to its normal anatomical site of the scrotum. So remember these two exchanging organs. A kidney failing to ascend, a testis failing to descend. This may have a pathology and this may have a pathology. Tumor may develop in either ectopic testis or may develop in an ectopic kidney. Hydronephrosis in ectopic kidney. Polycystic disease in an ectopic kidney. So remember these two exchanging organs. Ovarian cysts, as we have said, biosalpinx which is suppuration in the fallopian tubes, um, and so on. Lastly, we come to the hypogastrium or the supra pubic region. Any one of the previous mentioned may present in the hypogastrium, but at the end of our clinical seminar, I will illustrate something interesting and funny at the same time. Sometimes when you are a house officer, uh, you are going to see a case which is a suprapubic or hypogastric mass in a patient which is having, urethral catheter, and he is bedridden for a long time, or he is in the post-operative period. Any one of you can expect which type of mass is this? I'll be happy because if you answer, I will know that there is a complete understanding of our clinical seminar. Again, all the patient, male or female, with hypogastric mass is having no urethral catheter, and he is bedridden or he is in the post-operative period after a major abdominal operation. Can you guess which type of swelling is this? Yes,
Incisional hernia.
no, there is a possibility of retention of urine, and this represents a vesical mass, huh? A urinary bladder mass. So a full bladder or a retention of urine may present as a suprapubic mass. To complete your knowledge with this mass, so this occurs in the presence of no catheter in a bedridden patient, but if you compress the mass, the patient will experience the desire to urinate. Again, it's suprapubic, it's dull on percussion. If you compress, the patient is having the desire to urinate. At the end of the clinical seminar, we have discussed the abdominal pain and we have discussed the abdominal mass. How to investigate? You are going to do the routine lab investigation, blood picture, where you can detect the presence of anemia or leukocytosis. Leukocytosis may indicate an inflammatory lesion, liver function test, and then the tumor markers. Tumor markers are very interesting in diagnosing the abdominal masses. So you do the carcinoembryonic antigen, carbohydrate 19-9, CA 19-9, pancreatic oncofetal antigen. All of them can indicate the presence of abdominal malignancy. Each abdominal malignancy is having some sort of tumor marker that's elevated. In such cases, then go down to the liver function test, bilirubin and liver enzymes, alkaline phosphatase, renal function test, because it can reflect an idea about a renal cause of pain or a renal cause of mass. Then the master of abdominal diagnosis is the abdominal ultrasound. Number two, in some cases in which there is an initial idea with the ultrasonography, you can do abdominal CT, abdominal MRI, PET scan can diagnose malignant lesion by the protein emission used in positron emission tomography or the PET scan. Okay, you can take biopsy, whether it is ultrasound guided or it is CT guided needle biopsy, in order to gain a pathological diagnosis of this lesion. Then the management is very wide, subject to discuss in each item when you study, because tumor of site 1 needs treatment in such a way, in different ways, on side 2, side 3, and so on. I hope you got a logic idea about the abdominal pain and abdominal mass regarding the clinical point, regarding the investigation, and regarding how to diagnose. I'm waiting for any questions, any unclear points to illustrate. I can give you a handout of the illustrations on your WhatsApp. If I remember the one who has spread the photos on the WhatsApp can call me on the cellular phone, and I give him a handout of the lecture as a whole with all its contents, illustrated contents. Okay? Yes, Ahmed.
Okay, thanks, doctor.
Any questions?
Doctor,
Yes.
during abdominal examination, are all the cases examined on supine position?
Abdominal cases are examined on the supine with the examiner on the right side of the patient.
Only the supine position?
Yes, sir. Except some rare cases in which there is a small amount of ascites, you can examine your patient in the knee elbow position. But this is a very old fashioned, and the presence of ultrasound, we never say, I examine in the knee elbow position. Sometimes you may turn the patient to one side, but after starting your examination on the supine position, you can
So,
get some lesions when you turn the patient to the lateral side.
the abdominal hernias are included in abdominal examination. Right?
Abdominal hernia are a single, يعني separate item. It's a separate item. Abdominal masses don't include abdominal hernias. Abdominal wall hernias are something very different. Our subject today, which is abdominal mass and abdominal. Yes?
Okay.
Because of the hernia, you will examine your patient in the standing position. Sure. So omit the hernia from our subject of today.
Okay. Thank you, doctor.
Thank you, everybody.
Any question, guys?